Ladies and gentlemen, I would like to thank the International Federation of Fertility Societies for allowing me to talk to you about the British Fertility Society. My name is Raj Mathur, and I'm chair of the British Fertility Society, or an organization that we know as the BFS. The BFS is a multidisciplinary body which represents professionals who are involved in delivering fertility care to patients requiring this. Our members include doctors, nurses, scientists, counselors, and various other disciplines that are involved in this process. We work very closely with other sister societies and professional organizations, but also, importantly, the patient representatives and the national regulator of fertility services in the United Kingdom. Our history goes back about 50 years this year. We were founded in 1972 at the initiative of Patrick Steptoe, the pioneer of IVF. The first informal meeting of people which led to the creation of the BFS was actually in Patrick Steptoe's hotel suite during a conference in Athens. The first committee was formed the year after, and the first clinical meeting was held in 1974 in London. From the very start, the BFS has been a multidisciplinary body. In 1973, Steptoe wrote to 50 practitioners inviting them to join, and by the time the first meeting happened, 34 had already joined. Of these, the majority were gynecologists, but there were eminent representatives from other disciplines, including Robert Edwards. Initially, the plan was to restrict membership to only 75 individuals, but this number was soon exceeded. And in 1983, it was expanded further when a radical change was made to allow more scientists, nurses, junior doctors, and counselors to join. And I'm pleased to say that the society today reflects this multidisciplinary ethos which was present from the outset. So our current membership is just over 1,200, and the majority of members are clinicians, but we have a significant number of nurses and scientists, but really all sorts of disciplines that are important in the care of fertility patients are represented in this society. We have an executive committee which is led by an honorary president who is elected by the committee. As chair, the chair is elected by a vote of all the members of the society. It's a democratic process, and we work on the principle of one member, one vote. We also have a secretary and treasurer who are elected by the elected members. There are 12 elected members who are elected by one member, one vote by all members of the society. But in addition, we have co-opted members and ex officio members who help us in our work in progressing the aims of the society. Originally, the BFS was set up to provide a forum for gynecologists with a special interest in fertility. And the idea was that they would form a traveling club where members could go from one hospital to another and where they could be demonstrated surgical procedures that they had expertise in. So for instance, at one of the early meetings, Patrick Steptoe demonstrated laparoscopy, of which he was a pioneer, and Professor Swollen from Sweden demonstrated microsurgical salpingostomy. A further early motive was to affiliate with the IFFS, and that is why it's a special pleasure delivering this presentation to you, and we continue to cherish this relationship. But also from the start, part of the aim was to encourage research, to encourage the study of problems of human reproduction. However, as time has gone on, our aims have had to evolve. And part of the reason why they've evolved is because there are different challenges to fertility care in the United Kingdom now compared to what they were when it started. For instance, access to state-funded care is very variable in the UK because decisions about what should be funded are not made nationally. They're made by local organizations, which are called clinical commissioning groups, or CCG. Nationally, there is a very clear recommendation by the National Institute of Health and Care Excellence. You might know this body as NICE. And NICE have made very clear recommendations that 3 cycles of IVF or ICSI should be provided when the female partner is aged 39 and under, and in certain circumstances, 1 full cycle if the woman is between 40 and 42 years of age. And further, NICE go on to describe what a full cycle of IVF means and the circumstances in which it should be provided. However, In practice, in actuality, very few clinical commissioning groups fund the full NICE recommended 3 cycles. And there's a significant geographic variation. In the UK, we call this the postcode lottery, because literally how much IVF you will be funded for by the state depends on where you live on the postcode. And this map, taken from a commercial report going back to 2016, hasn't changed very much in the intervening 6 years. So only few areas, and those are mainly in Scotland, which is not shown in this map. This map relates to England, fund 3 cycles, which are in green. A number fund only 1 cycle, which are represented by the yellow or colors, and some fund 2 cycles, which are represented by the orange colors. And tragically, there were several areas in England that don't fund any IVF, and they are the ones that are gray on this map. In addition to not funding the full treatment, our patients are faced with other problems. For instance, there are a number of other criteria which are not medical criteria, which are social criteria that have been applied by the clinical commissioning groups for funding for IVF. And these criteria are not applied consistently. They vary from one CCG to another. So our funding for IVF in the UK has become extremely heavy in terms of private provision. In 2018, almost 70,000 cycles were carried out in the UK, and the proportion funded by the NHS in England was only 35%. The situation was much better in Scotland, where it was 60%. So the majority of cycles in the UK are funded privately. And please remember that there is no insurance coverage for IVF in the UK. So the patients are paying for this out of their own pocket. And of course, private costs can vary quite a lot from one clinic to another. And the way the private costs are presented to patients can make it very difficult for patients to compare the costs between one clinic and another clinic. We believe in the BFS that state funding of IVF is important. It is important that the state should fund the 3 cycles, because this is the most cost-effective way to maximize the chance of a couple having a baby. It is also an argument of fairness, because funding 3 cycles gives an equal chance to women who produce a smaller number of embryos. It also encourages safe clinical care, because if you have more cycles funded, you're less likely to transfer multiple embryos. And of course, it is equitable, because it allows people who have subfertility a chance to have a baby irrespective of their own personal wealth and resources. And we know also that our patients suffer quite a lot because of poor state funding, and there have been several patient surveys. And of course, our own clinical experience day to day in our clinics reveals the negative effects that funding problems have on the mental and physical health of patients, on their use of various medications, on problems that they experience at work, and even relationship difficulties. As a result, the aims of the British Fertility Society in the modern day have to take into account the problems that our patients and practitioners face. So broadly, we have 2 overarching aims. The first is to advance the education and improve the practice of health professionals for the public benefit. And the second is to advance the education of the public on the science and treatment of infertility. I will not read out each of the sub-aims, but they're really quite diverse and extensive. I've highlighted point E, which is promoting equality of access to fertility treatments. And you will see from my previous description why that is an important aim for our society. We do a number of activities to support us in achieving these aims. A really important part of our work, which we value a lot, is our training activities. So we have something called a study week, which covers a wide range of skills and knowledge that is required for practice in the area of reproductive medicine and fertility. I've listed here all the modules. This is on a modular basis, and we have different modules where you can sign up to receive training in these specific areas. We had a target last year of delivering 264, and we've crossed that target. This is a little pat on the back for ourselves that in a year which was blighted by the pandemic, we nonetheless managed to exceed the target that we had set ourselves for delivering training. In addition, from the point of view of training, we deliver a very important course in collaboration with the Royal College of Obstetricians and Gynecologists. This is the RCOG BFS joint course on subfertility and assisted conception. This has recently been highly successful. We had nearly 200 delegates from 26 countries. I'm pleased to say that if you're from a band B or C country, you get a reduced delegate fee. And we've had uniformly really good and excellent feedback for the content of this course. We are very keen to work with the IFFS and with sister societies abroad, overseas societies, to disseminate good quality training. The fact that a lot of our training is now delivered virtually, it really helps us to think in inventive ways, because you can allow asynchronous access to people in different time zones. And this can all be supplemented with hands-on training in the home country to achieve certification by the BFS for people in your countries who are interested in obtaining that certification and that training. Please contact us if you would like to talk about this. We also have a very important role in arranging annual meetings, which we call the Fertility meeting. This is done in association with our sister societies, the Society for Reproduction and Fertility, and the Association of Reproductive Clinical Scientists. Our next meeting in January 2023 is in Belfast. It is going to be an in-person meeting. The theme is Reproduction in an Aging World. It is going to have an exciting program with lots of eminent speakers, a vibrant social program in a really interesting city. Again, international colleagues are extremely welcome to join us. A large part of our work in the BFS is to improve the standards of professional practice. And in order to do this, we have a policy and practice committee, which has a large portfolio of guidance. This is a list of some of the things that we are currently actively preparing guidance on. Of course, a major thing recently has been the pandemic, and we set up a joint working group with our colleagues in ARCS. And this working group had membership from across the professional spectrum, but also the state and private sectors. And we work closely with the Royal College and with our regulator, the HFEA. So our guidance on COVID-19 is publicly and freely available to all, and it is updated constantly. We have a journal, Human Fertility. The impact factor has gradually risen to nearly 2.8. And the majority of submissions to Human Fertility are from international contributors. If you're a member of the BFS, of course, you get free access to this journal. We take public engagement very seriously. So when the pandemic happened, we pivoted in a large way to social media and to producing resources that help to reassure the public about the need, the value, the efficacy and safety of COVID-19 vaccination in relation to fertility. We've had different media stories that we respond to. We have actively carried out webinars for patients with patient organization. We have a fertility education initiative that focuses on public awareness of infertility and fertility. And we've created a package for senior school science students to interest them in a career in fertility. I would like to thank the IFFS for having given me this opportunity to talk to you about the British Fertility Society. And I hope I've been able to give you a taster of what the Society does. And I hope I've been able to convey that we're very keen to collaborate with yourselves, with colleagues and professionals from across the world. I'm very happy to take questions and discuss what I've just presented. And I thank you all once again.